Michelle Anthony, and I'm a medical student at University of Arizona. Gallstones is a very common entity that often leads to complications requiring surgical intervention. The goal of this presentation is to demonstrate the role of MRI/MRCP as a valuable addition for its diagnosis. A common complication stemming from gallstones is acute cholecystitis. While ultrasound remains a valuable tool for its diagnosis, several factors such as bowel gas may limit its utilization. In contrast, an impacted gallstone can be seen on various MRI sequences as a round signal defect in the neck of the gallbladder or cystic duct. These sequences include T2 weighted image, T2 spare, and pre and post-contrast T1 weighted image. Post-contrasted T1 weighted image can also show gallbladder wall thickening and inflammation with increased enhancement. Perforated cholecystitis is a rare complication that occurs as a sequelae of untreated cholecystitis. Compared to ultrasound, MRI's higher soft tissue resolution can identify smaller perforations. For example, as you can see on the spare image, there is severe gallbladder wall thickening and edema with discontinuity of the wall anteriorly with associated intrahepatic abscess. Common bile duct stones is a complication that may be difficult to diagnose using ultrasound. As you can see on the MRCP, clearly shows a distended common biliary duct with a filling defect in the distal segment representing a stone. Gallstones have also been implicated as a major etiology of pancreatitis in certain populations and can be viewed with T2 weighted image and T2 spare sequences. On T2 spare images, you can see increased T2 signal consistent with edema and inflammation of the pancreatic body and tail, as well as gallstones within the gallbladder. BOUVERET'S syndrome is an uncommon complication of gallstones that can result in gastric outlet obstruction when gallstones enter the duodenum. MRI sequences such as T2 with fat suppression are often utilized to demonstrate a large gallstone, proximally dilate gas-filled bowel, and hyperintense thickening of the gallbladder wall. Addition of post-contrast T1 weighted image can illustrate bowel wall enhancement and secondary findings of inflammation. A common treatment of gallbladder-related pathologies is cholecystectomy, which can cause dropped gallstones in the dependent portion of the abdominal cavity. These may also occur with gallbladder perforation. Many sequences, including both T1 and T2 weighted image, can clearly demonstrate most gallstones as a round foci of low T1 signal, which would be a cholesterol stone, or a high T1 signal, which would be a pigment stone. The addition of T2 spare can demonstrate extensive inflammatory changes. In conclusion, MRI and MRCP is a valuable addition to the diagnosis of gallstone and its diseases because of its high resolution as well as tissue contrast. Thank you for listening to my presentation. Have a great day.